As everyone was talking this afternoon, I was writing down all sorts of things to ask, and I have way too many things to cover in 20 minutes. I am not giving away free cars now that Oprah thing has been brought up. That's not happening. I think one of the things that I'd like to talk about to start with for both Mark and Ravi is about the importance of clinical trials. Right now we have, as of this morning, we have 14 clinical trials for multiple myeloma open here at Washington University. And all the drugs you heard about today, drugs that all of you have taken, like Revlimid, Velcade, Kyprolis, and I won't go through all of them, were approved because of clinical trials, and most of those drugs were available here prior to their approval. So if you guys could just talk a bit about clinical trials in general and why they're so important.
I think that, as somebody aptly said at a recent conference that I was at, that who's the first person who's going to be permanently cured of who's the first person who's ever going to be cured permanently of myeloma? It's going to be a patient on a clinical trial. So I think that brings out the importance of clinical trials. We have trials usually in all phases of treatment, right from people undergoing early treatment to late treatment. And for those that are not candidates, not everybody can unfortunately be a candidate for a trial because you need to fit certain criteria for kidney function, for blood counts. But the fact is that we try our level best if patients are eligible for clinical trials to get onto clinical trials. Also, you heard about real-world registry data. We have all those registries that were put up there, the Connect registry, the Insight registry, the Preamble registry, open for patients. And even if you're not eligible for a clinical trial, your data can contribute tremendously to these registries, and that is something that we again approach patients about. And then we have our banking study, which whenever we do a bone marrow biopsy, often will ask you if we can use a small sample for genetic research. And that is what goes into all this genetic data that we put up there. And I think we are well situated as one of the few centers in the world that can really bring path-breaking discoveries in this area.
So I would echo what Ravi says, but I think that as what's a patient's motivation to do a clinical trial? I mean, it may be altruism. You want to help the next patient, right? The only way we're going to advance the treatment of myeloma or get new therapies, we can't just you can go and take a therapy, whatever you want off the counter from the pharmacy or your local homeopath, but you're not going to lead to the approval of a drug in the United States and the ability of other patients to get that same drug unless patients with the disease have the drug tested on them. And some patients look at the data that I presented. There's two curves. There's some patients that do better than the others. That's always the possibility of a clinical trial. But all of the trials in oncology, I tell patients, are designed where they're active treatment trials. You're not, in most cases, getting a sugar pill. There's some active treatment in addition to drug X, Y, or Z. And that's the only way we learn that drug X is better than drug Y, is by doing the clinical trials. And at the end of the trials, yes, some patients in those trials have their disease maybe progress sooner than others, but that's what leads to the advancement. That's what's going to lead to the time that patients go between therapies being prolonged and the response is deeper, is by participating in clinical trials. And the knowledge that we have about the cancer itself was only gained because patients participated in trials. It's because we asked them at the time when they're diagnosed, are you going to donate a sample of your bone marrow? It's not going to help you at all. We're going to take those cells and we're going to sequence those cells, and that's the knowledge gained from that is what I tried to highlight, is that myeloma is not one cancer cell, it's multiple cancers within each individual. And as we have more patients participate in those type of trials where we just take their cancer and we're just using it for research, we're not giving you any of the information, it's going to help us to understand how the myeloma changes when we give these drugs that are approved so that we can develop new drugs that are even better to treat the myeloma. We have a number of clinical trials available at WashU. There's resources online. You can go outside of our center to find clinical studies, but because there's a limited number of patients with your cancer, the more patients that participate in trials means that the quicker drugs are going to be developed, the sooner potential cures will be developed for myeloma.
Great, thank you. So one thing, if you guys read the New York Times, you'll see every once in a while an article comes out about CAR T cells, and they're very exciting, and certainly we have experience with cousins of myeloma like leukemia, lymphoma, but if you read those articles, they never mention side effects, and I think one of the things I'd ask both Ravi and Mark to comment on is a little bit more about some of the toxicities of immune therapies, whether it's CAR T cells or the bispecific antibodies or PDL inhibitors.
So I think that the two main classes of toxicity of CAR T cells, or these bites to some extent, is what we call cytokine release syndrome and neurological toxicity. These cells, once they get reintroduced into the body after being genetically modified, are revved up to attack the cancer. They're multiplying. And when they do so, they secrete chemicals that are going to then make patients spike a fever, sometimes drop their blood pressure, in some rare cases also end up in the ICU because of low blood pressure. In a few cases, it can also cause some change in one's mentation. People get a little drowsy, get a little confused. The fortunate thing is that the current generation of trials for myeloma have much lower of these side effects than the ones that we have commercially available for lymphomas and acute lymphoblastic leukemia, where the rates of these side effects are much higher. And that actually is allowing these CAR T cells in myeloma to more rapidly move into earlier lines of treatment. In a few months, we literally have a CAR T cell trial available for patients as part of their initial therapy. So that's how rapidly these things are moving along.
I think that's an important point that Dr. Vij makes about trying to compare the results from one cancer to your cancer is dangerous when looking at these immunotherapies. Everybody's gonna, and within the immunotherapies, there's a different spectrum of toxicities. One thing we're learning as we study these cellular therapies, in myeloma, yeah, the toxicity profile is going to be different than lymphoma. So if you've seen publications about the approved therapies for lymphoma, it doesn't mean that the CAR T cells we're using in myeloma are going to have the same toxicity. We know that some of the toxicities are similar. And it's these are therapies that are right now being tested in patients who have had multiple progressions of their myeloma, and it's a risk-benefit for those patients. Under the right support and in the right environment, we're able to get patients through those acute toxicities that outside of a hospital setting or ICU setting, you could potentially die of those immunotherapies, the CAR T cells, but with the right treatment and support, patients are able to be pulled through. And the advantage of doing research and discovering more about the CAR T cells or the next generation of these cells is that the toxicities hopefully will improve. They will improve. We learn more about the side effects, about how to engineer those cells, how to change that initial, Model A car and make it the Lamborghini like Dr. Vij that has less toxicity and goes and still kills the cancer. So it's early days. Toxicities right now are unavoidable, but I think things will improve in the future.
I like that you chose a Lamborghini because I think that's the car that costs about as much as a CAR T commercially. I was going to talk about cost, but just, we talk about the cost of CAR T cells, but a lot of these drugs are very expensive. Transplants are very expensive. Those Revlimid pills you take are $800 a pill, and the Ninlaro pills are $4,000 each. You only have to take one a week, so it sounds a little better. that way. But I think overall, one of the things that Dr. Vidge brought up, and is something that's going to need to be figured out, is as these new therapies come and they come with a substantial cost, is how that's going to be taken care of. And again, there's no answer to that. We need another day to start talking about that, but it's just big picture part of things. One of the things that Dr. Schroeder mentioned and was mentioned earlier was about the bone marrow microenvironment and how important that may be in terms of how our therapies work, or trying to determine how a patient is going to respond to therapy. So if either of you could address that or some of the research going. Oh, sorry. So what I've asked them is talk a bit about the microenvironment and also some studies that are looking at those sorts of things here. So the microenvironment, so it turns out, if you try to grow a myeloma cell in the laboratory and put it in a glass dish, most cancer cells are pretty happy. You give them some food and they'll grow. And myeloma cells need some signals that they get from the cells around them. They're much happier with other cells around them. They're much happier attached to their home than they are when they're floating around. And that may be very important in terms of how we treat myeloma as we go forward.
So just to maybe expand on that, the microenvironment, so you know that myeloma is in the bone. So we're talking about the cells that are with the myeloma. Often in these presentations, we're talking kind of in a vacuum. We're just talking about the cancer cell. But actually there are blood vessels, blood cells, there are immune cells that are in the environment of the myeloma within the bones that help to support the growth of the cancer. We know that some of the drugs that we give for the treatment of myeloma alter those supporting cells, and that's one of the ways that they mechanistically work. Newer research studies are looking to try and stimulate, say, the growth of cells that are around the myeloma, the immune cells that should be attacking and getting rid of the cancer, to let them attack and get rid of the cancer. And the immunotherapies that we talk about, the daratumumab, the elotuzumab, those work in conjunction with the microenvironment, with the cells within the bone marrow to attack the myeloma cell. That's one of the mechanisms by which they work. Some of the therapies within the CMMN, the Multiple Myeloma Nanotherapy Center, is looking to try to track myeloma by specific molecules on their surface, and those molecules interact with that microenvironment, so you could potentially disrupt that interaction. The myeloma lives best in the bone marrow because those cells are supporting it, right? You can't culture myeloma easily outside of the bone marrow. You need other cells to support it. So the newer therapies are not only directed at the myeloma, but directed at those supporting cells to try and kill them.
So one of the things that we're trying to understand better is how best to look at myeloma. One way is to look at the bone marrow. One way is to look at the bones in different ways. And one of the newer therapies that many of you probably have had is a PET scan. Has anyone had a PET scan? Well, PET scans are pretty non-specific, and one of the things that I'm waving to Dr. Shokeen, who doesn't have a microphone, but when we try to figure out where the myeloma is, with a PET scan, we give you some sugar that's radioactive, and myeloma cells will eat it up, and we can see them. But as part of the CMMN work, Dr. Shokeen is trying to target specifically the myeloma cells and make them light up. You want to address that a bit?
Yeah, I think that again, the fact is that we are, as part of our research efforts, not only trying to improve upon the drugs, but we're also trying to improve upon the diagnostic modalities that can better develop information about the extent of the disease. And I think that Monica probably could expand on her, scans. If you want to give her a mic, I think that would be good. So I think some of you actually in this very room have taken part in some of her imaging studies. She's trying to develop a better way to really quantitate the myeloma. What we're learning with myeloma is that actually myeloma, even at any given time, is not one disease. It has been shown that myeloma present in different areas of the body at the same time has different genetic makeup. So you can actually sometimes kill the myeloma cells, but they may grow in only one area. And that has been shown that this is because of different genetic events that occur in different parts of the body. And so imaging is very important in this regard.
Yes, thank you, Ravi. And first of all, thank you, everyone here. Like Ravi mentioned, our research and development depends upon patients like you who come and sign up for our new agent. So the imaging agent that we are trying to develop, for me, it's been almost 10 years now, going from literally bench to bedside, is to how can we better find myeloma cells within the whole body. They could be just small subsets hiding behind the bone, and so a blood test or a urine test tells you, yes, you have disease, but an imaging scan will tell you where is the disease, okay? And so we are trying to be more sensitive. So functional changes in the bone marrow happen before the anatomical changes, meaning we want to catch the disease before the bone starts to break, before we start to see a lesion in the bone. So, and Ravi and others have explained it to you well. So, and also as part of CMMN, we are trying to combine the power of whole body imaging with therapeutics so that we can have the dual and more targeted killing of the cancer cell within that area and sparing the normal organs so that we have lesser side effects. So thank you for your support, and hopefully next year you will have much more patient data. Thank you.
All right, I think I'll probably get one more question in. So one of the things, we focused a lot on how we treat the myeloma, and I think one person mentioned Zometa and bone protection. So what I'd ask Dr. Schroeder and Dr. Vid to talk a little bit about are things that are important as part of the therapy for someone with myeloma that is not the chemotherapy, and specifically how we support the bones, how we support red blood cells, how we prevent infections.
Okay, it's a very important topic. We glossed over. We were focused on the drugs specifically for myeloma, but those drugs have side effects. We know that myeloma destroys bones. Part of it's because of the factors the cancer is secreting in the bones, and a way to prevent the destruction of the bone is to use drugs that stop that resorption of the bone, and that's what the bisphosphonate does. It helps to prevent the myeloma from destroying the bone. While we kill the cancer, we want to stop destruction of the bone and allow for growth of the bone. So that's an essential element to anybody who is being treated for myeloma, and it will be used whether you have lytic bone disease on x-rays or the little moth-eaten areas on x-rays or not. And that helps to prevent, number one, further destruction of the bone, and number two, it's been shown to prevent fractures or breaking the bones in patients with myeloma. Our typical course of that treatment is to use it for a couple years from the diagnosis. Beyond that, the risks may outweigh the benefits, and then we often will resume it at the time when patients relapse with their disease. So the bisphosphonate or the Zometa or Xgeva, those drugs help to protect the bones and help to prevent fractures. The side effects, some people may have bone pain when they get the drugs. It's transient, hopefully it's manageable. The other drugs that we use, the steroids and the immunomodulatory drugs, the Revlimid, pomalidomide, those increase the risk for blood clots. Anybody with cancer has an increased risk of blood clots. Myeloma is no exception, and when we use the drugs to treat myeloma, there's an increased risk of having blood clots. We want to prevent that, so we'll often recommend an aspirin, or if you're somebody that has had a blood clot before, you should be on a blood thinner, especially when you're on Revlimid or pomalidomide treatment for your myeloma. The other thing that we also try to prevent are infections in patients with myeloma. We suppress your immune system with these drugs. We give you steroids, we give you the immunomodulatory drugs. They suppress your immune system. One infection we want to prevent are viral infections. So acyclovir is common to use in patients with myeloma. And as we learn about some of the newer therapies, we may use other antibiotic prevention as well in patients with myeloma.
So Keith, what about neuropathy? I guess I'll ask you a question.
Okay, I can do that. So, I mean, I think, neuropathy is something that we see very commonly. Unfortunately, and maybe there's something important about this, but a lot of the drugs that are active in myeloma cause nerve damage, and maybe that has something to do with myeloma cells and nerve cells somehow being similar. I'm not sure. But even the old drugs we used to use, a drug called vincristine would do this. Certainly the proteasome inhibitors like bortezomib or Velcade and the IMiD drugs can do this as well. And so I think one of the things that's very important is that neuropathy can show up in a lot of different ways, and it's very important for people who are on therapy to make sure your doctor knows if that's starting to happen. So we always ask about numbness or tingling in the fingers or toes, but in some people it can just be muscle cramps, that the hands or feet are cramping at bedtime. Sometimes it's just people will come in and say, my leg hurts. Not that, and they don't think to mention that their leg hurts because they don't have numbness or tingling. But those are very important things because one is we would change the dose of medicine. Sometimes we take a break from a drug, but we also have a lot of medicines that are very helpful for neuropathy. So drugs like gabapentin or Neurontin, Lyrica, and then an antidepressant called Cymbalta seems to actually be very effective in many people with neuropathy. So I think it's very important to make sure that you let your physicians know if those sorts of things are happening.
Yeah, I think prevention is the best part of neuropathy. And once it's set in, it's a little difficult to reverse, and because nerves regenerate at a very slow rate, and all you're trying to do with Lyrica, Cymbalta, gabapentin is mask the symptoms, or sometimes even give opioids till the nerve fibers regenerate. The good thing is with Velcade, in about 80%, there is at least some level of relief, and in half the patient, total relief of their symptoms, but it takes months to happen.
I mean, certainly a lot of people on steroids will complain of muscle spasms, especially when they are coming off steroids. So we usually don't use them to actually treat muscle spasms.